I'd like to invite our first distinguished panel of experts and expert moderator to the stage. I'll introduce just in less than 45 seconds this panel. They understand how the dietary guidelines impact our nation's most vulnerable populations. The dietary guidelines are used by the U.S. and other governments as the basis for food assistance programs that serve children, the elderly, and the food insecure. Dr. Cheryl Achterberg, who is, of course, our Dean of the Education and Human Ecology efforts underway at Ohio State. Cheryl advances world-class scholarship, not only as Dean, but which is an administratively intensive leadership assignment. She is a respected and renowned scholar in our field. Dr. Achterberg is an accomplished author, an award-winning teacher, and serves as a member of the 2010 Dietary Guidelines Advisory Committee. She's also a charter member of our Food Innovation Center. She has a clear vision of what we can achieve with dietary guidelines and serves as our panel moderator today. And she also is a really nice person that you'll enjoy meeting. So, please, to the panel.
Thank you, Ken. Good morning to everyone. The name of our panel is Addressing the Needs of Vulnerable Populations, and I want to thank our previous speakers for setting us up perfectly to explore this important issue a little deeper. And it's an honor, I must say, for me to share the stage with these panelists, as you'll soon see. I'm going to introduce each of them. First, Dr. Lucile Campbell-Adams, directly to my right. She may have the longest title in the group as Professor of Oncology at Georgetown University Medical Center, Lombardi Comprehensive Cancer Center, and Associate Director of Minority Health and Health Disparities Research here in Washington, D.C. She's a woman of many firsts, the first African-American woman to earn a PhD in epidemiology, the first and only Black woman to head a cancer institute, and the only one at a historically Black institution. Her CV is literally dripping with honors and awards, too many to mention, but most relevant to us today is the fact that she served on the 2015 DGA committee and initiated the Black Women's Health Study. She specializes in community health research, interventions, and outreach relative to energy balance, diet, and exercise. Please welcome Dr. Lucile Campbell-Adams. Adams-Campbell. Oh, okay, off to a great start. Next, I'd like to introduce Dr. Benard Dreyer, a pediatrician with over 45 years experience and a New Yorker through and through, having attended NYU School of Medicine and working in the city ever since. What stands out on his CV is that he has a long and deep engagement with his major professional society. I don't want to mess this one up. The American Academy of Pediatrics. He is the former president of that society, and he is now the president-elect of that society. Listen a little bit to what he's done. He was chair of the Committee on Homeless Children for the New York section, chair of the Committee on Underserved Populations in New York, again, the New York section, chair at the national level of his society for the Health Literacy Committee, member of the Executive Committee for LGBT Health and Wellness Committee, and as I already said, the past president. Eminently qualified for our panel on vulnerable populations. Please welcome Dr. Dreyer.
As a veteran New Yorker, I took the shuttle this morning, which was an hour late. So
But he made it. Ginny Ehrlich, next, is the Director and Senior Officer of the Childhood Obesity Team at the Robert Wood Johnson Foundation. She's an expert in childhood health. She has a doctorate in ed leadership, an MS in special education from the University of Oregon, and an MPH from Boston University. I would describe Dr. Ehrlich as a, quote, doer. She's the founding director of the Healthy Schools program, the largest school-based obesity prevention program in the US, and it's active in all 50 states. A founding member of First Lady Michelle Obama's Let's Move campaign, and founding CEO of the Clinton Health Matters Initiative, which is was created to close health inequity gaps in the U.S. From 2006 to 2013, she was the CEO of the Alliance for a Healthier Generation. If you'll welcome Dr. Ehrlich. And Ana Maria Ciega-Reeks is a professor of epidemiology and nutrition, as well as, and I appreciate this, Associate Dean of Academic Affairs at the Gilling School of Global Public Health at UNC Chapel Hill. She's also a nutrition epidemiologist and has been involved in several very large cohort studies of Hispanic women and children, in addition to being a member of NHLBI's Advisory Council and also a member of the 2015 DGAC. Welcome. Well, let's plunge right in, and I am going to turn to Ana Maria. I know that you've led the Hispanic Community Health Study with over 13,000 participants, subgroups that included Puerto Ricans and Mexicans and Dominicans and Cubans. Can I just begin by asking, is there a Hispanic diet?
So thank you. Thank you for the introduction and the pleasure of being here. So my colleagues and I at UNC, who run the Coordinating Center for the Hispanic Community Health Study, which is over 16,000 Hispanics in the United States from 4 different sites. The work from that study shows, first of all, the term Hispanic is very misleading. It encompasses many different heterogeneous subpopulations, very similar to what I would say the terminology Asians. It represents many different individuals from different cultures, from different countries, and each one of them has their own dietary patterns. And that's one of the things that our paper that got published in the American Journal of Clinical Nutrition showed just very nicely, because it was the first time that we had ample numbers in all those different Hispanic backgrounds to be able to show that there isn't one Hispanic diet, but Cubans eat differently from South Americans, from Puerto Ricans, from individuals who come from Mexico. And so in fact, to lump them all together actually misses the nice diversity in the foods that they're consuming and in the messages that we can actually tailor to them to improve their dietary patterns, to improve their health status. So there's not one, there's multiple ones, and similar to our finding that out in the Hispanic population, it's very similar to when we study Asians as well, that there's many subgroups. And in fact, I think Americans being a melting pot, that there's many other ethnicities that we have yet to recognize the fact that they come with their own cultural dietary patterns that we need to be cognizant of as we formulate nutrition messages to improve health.
Thank you. And to just quickly follow up with one more question. Given that diversity, is there a special opportunity that you see that the 2015 Dietary Guidelines might address with this community, broadly speaking?
So the one thing that I have to say about the dietary patterns, and I worked really hard, I led that chapter on dietary patterns and health outcomes. Lucile's laughing because it took us a lot of time. But the one nice thing about the use of the term dietary patterns, and Mike McGinnis alluded to this, is the fact that we're focusing on combinations of foods that have come together that form the healthier aspects of eating that have been translated into optimal health. And in those dietary patterns and how we've described the scientific evidence, it basically shows that there's room for individuals from many different cultures to actually follow those dietary patterns.
So Lucile, I want to turn to you now. You've been doing intervention studies for a long time. I partnered when we were both young without gray hairs.
Where's this going?
Could I ask you, with that broad base of experience, what have you learned from those interventions that might help us shape what comes in the future with these 2015 dietary guidelines? What opportunities and challenges and lessons learned could we apply?
I think one of the biggest lessons that we have learned is that there's this myth out there that many people, vulnerable populations, minority populations, aren't interested in their well-being. And that's actually such a bad statement to make, but we hear it repeated, perpetuated forever. But the reality of it is, when people in communities and different populations are educated about the interventions, about the programs, about the process, about the importance, including the nutrition information and education, they're interested in participating. So we have the buy-in of the community. Once we have the buy-in of the community, I think we can actually impact positively the guidelines. But until we can disseminate and educate everyone at the level that's needed for the education, I think we can't do it. Even our study that we did a long time ago, I mean, it was for low-income minority populations. But the fact that we use the medium was playing cards that we had nutrition values on, we figured out how to reach out and connect with the community. And I think it's very important that we work so closely with the vulnerable populations, with the community, and get their input, you know, as to what will be effective or how we can really make a difference. Because we can publish all the dietary guidelines we want, but until we can disseminate it and show that and educate the community, it will not have any impact. And we really need to be very impactful at this point, because the diseases, the obesity, the overweightness, and chronic diseases that are related to those things will continue to rise. Even though we see, and it's already been shown earlier, that there is a decline in some of the chronic diseases. When we look at vulnerable populations, we don't see that. So I think that it might be misleading if we don't really focus on these populations need more, but they just need us reaching out and buying into the cultural practices, learning more about the community, and actually effecting changes with the community.
Thank you for that. Switching gears a little bit, I'd like to work now with Benard. You have worked in your career with lots and lots of special needs populations, what we might call special needs children, which is a group, I think, that I have not heard described or addressed in previous conversations about the dietary guidelines. What do you see as the barriers and opportunities for serving that particular group? And I allow you to describe exactly as you please what you think that label means.
Yes. So I think at one extreme, that label thinks of kids either who have disabling diseases or conditions or have chronic diseases. That's not an insignificant number of children. But I think I view children who are poor, who are in families who are recent immigrants, also as children who have very special needs. And I guess I want to step back a little and just state that one of the hopes I would have for the guidelines is to take a developmental approach to nutrition. The dietary patterns are great, and there's a lot of science behind them, but thinking about how those dietary guidelines play out over the lifespan, I encourage us to, first of all, have guidelines for 0 to 2 years of age, a critical period, which I know we're working on now, but are not included in the present guidelines. I think that's a critical period where nutritional patterns dietary patterns are started. And if we don't start there, we're losing a lot of ground. There's very little information on preschool dietary, how to implement and what those diets and what does it mean to a parent to take those dietary patterns that we recommend and give a healthy and nutritious diet to their child. So I guess my first concern about any of these vulnerable children would be to take a developmental approach to diets. A 2-year-old is very different than a 6-year-old, obviously different than an adolescent and different than an adult. And I don't see a reflection of the science necessarily there. We have a lot of research in young children, but I'd like to see the guidelines to take that on as a very important role. This is especially important to our country, I think, because dietary patterns that children develop actually precede their adult life. And we know that children's dietary problems and obesity move into adulthood. So if we're really going to do something about obesity and malnourishment in adults, we really have to start in childhood, and in fact, probably in early childhood. So that's one area of deficit that I think, I would like us to view obesity as a developmental disorder of children, of childhood. Much obesity starts in childhood and it develops in childhood. And, we in pediatrics obviously view it that way. We're very involved in trying to do something about childhood obesity. I should comment that in my day job, outside of the American Academy of Pediatrics, where I'm president-elect, I have for the last 40 some odd years taken care of poor immigrant children in New York City, mostly what we would call Hispanic or Latino, of multiple kinds, but mostly Mexican and Caribbean, but many other cultures from across the country. And so I'm aware of the cultural issues as well. In my research, my group has 2 research projects, one funded by the USDA, thank you, USDA, and one funded by the NIH. I don't know if the NIH is represented here today somewhere, but both of them are looking at helping parents change those patterns in early childhood, because that's, I think, by the time even a child is 4 or 5, it is hard to change those patterns. So that would be true for all children, but especially vulnerable children. I would say, second, unfortunately in our country, children are the poorest group of our society. About 20% of kids are poor, much higher than any other group, any other age group. And actually almost half are poor or near poor, and we know that food insecurity, it's almost half of those kids live in food insecure homes. So, so those kids, which are a large portion of our children, those parents are dealing with food insecurity as well as the epidemic of obesity at the same time. And those things actually go together, as we know. They're not separate. So thinking about and getting more science is how can we intervene early in food insecure families. I know that Secretary McGinnon brought that up, Kincannon brought it up earlier. I think that's a real need. And getting to the concept of looking at the mind, the totality, as Dr. McGinnis said, it's making these real for families and children. So understanding how to deal with families who are dealing with food insecurity and then are presented with guidelines that are scientifically based, but tell them to get more fresh fruits and vegetables and give up cheap fast foods, which are easily available. It needs to be something we understand how to do if we're going to make a difference.
Thank you. Ginny, turning to you, I know you've devoted a lot of time and effort on this whole issue of childhood obesity, but let's focus on the adolescent issue. I know when we look at the data, nutrient inadequacies, particular nutrients are probably more prevalent among adolescents than any other age group. At the same time, obesity is a big concern. So what sorts of insights have you learned about the barriers? Is it mostly age? Is it mostly income? Is it mostly cultural? What's the trick in working with adolescents?
So I think it's I want to kind of confirm the importance of the developmental perspective if we look at this. By the time that kids enter adolescence, their patterns are really established. So it's hard to for me, identify kind of what's discrete there, other than the fact that there's a lot more independent decision-making happening, obviously, during adolescence, which then might exacerbate some patterns that might not be so positive that have been developed at 3, 4, 5 years old early on. I think that as we look at different interventions and we look at different components, it's really listening, designing for the consumer. And I'll take the school environment. We're seeing great adherence to the guidelines under the Health and Hunger Free Kids Act, which is fantastic. We also see a decline during adolescence in participation in free and reduced lunch. And part of that is that there's more of a sense of stigma for the kids. So even, they don't want to sign up, they ask their parents not to sign up, and Or even if they're signed up, having worked in schools for a lot of my career, they won't eat in the cafeteria because of the stigma. And that just exacerbates the inadequate, kind of the nutritional inadequacies you're talking about. They're going across the street, receiving less healthy options, et cetera. So it becomes cyclical. I think the positive thing is that schools are starting to solve for that. We're seeing some really great examples of work in terms of not only trying to eliminate stigma, but also, putting salads in a vending machine. In Miami-Dade School District, they have salads and vending machines in the high schools. Because you know what? The kids aren't going to the cafeteria, they've solved for that. They've created different ways to make it so that, any person in the school environment, if the vending machine's attractive to a teenager, figure out how to use it positively and put healthier options in it, including using your swipe card. So those are some kind of examples. I think we also see in adolescents a decline in physical activity for a variety of reasons. And I'm thrilled to see that the new dietary guidelines are very comprehensive in terms of culture, in terms of the whole picture of what a healthy lifestyle looks like and what a culture of health needs to look like in a community. For kids who are living in poverty, we're seeing a decline in physical activity because we have pay-to-play models. And those models become more and more pay-to-play the older the kids get. We also know that high schoolers and even middle schoolers have become responsible for taking care of their younger siblings. And so that eliminates the time available for physical activity, which exacerbates then again the issue of obesity and the inclining rates.
Emery.
So I wanted to comment a little bit on what Benard had brought up in terms of looking at the dietary guidelines from a developmental perspective. As you know, there has been a special initiative called Birth to 2 Years of Age, right? That is starting to look at the evidence through systematic reviews to be able to prepare for the 2020 guidelines, which I think is great. It's definitely needed. Your points are very well made that, in fact, the more that we can be there to help inform and at those critical stages of life where you're developing taste preferences and training cues of hunger within your own body to be able to identify that so that we can literally grow and develop in a more sort of normal physiological process that we've been used to, the better off we'll be, because even while adolescents will explore and take risks during that time period, what you see is if their parents have laid down a good foundation, they'll come back to it. And so that's the importance of it. But the one thing that I have to say that I'm hoping that people, when they read the science report, which I know is really long, but there are really strong statements in there that says, we haven't devoted enough research to birth to 6 years of age. That the amount of money that we're spending on research for young kids to be able to understand how best to prevent these chronic diseases is really outstanding in the sense of why? We're spending so much money at the other end and not necessarily doing it at this end. So in order for us to come up with really good dietary guidelines, I really hope that we end up getting more funding for those kind of programs. There's a great preschool program called Knapsack that actually has gone across the nation in training preschool personnel how to follow dietary guidelines. That's the kind of information we need to have in every single program.
Can I just
Sure.
comment on that? I just want to absolutely agree. I think that there is a real need for research to truly understand how to do it, not so much even the what, but the how. And also to bring to scale programs that have been proven effective. So thank you for making those comments because, I just wanted to make one other comment. In wearing another hat that I sometimes wear, I was on the IOM Roundtable for Health Literacy. And I just want to bring up the issue of health literacy in this endeavor. And you sort of triggered my thinking about that in your comments. But in our intervention with mothers of young children, to think about how to change not dietary patterns, but dietary amounts and their understanding with young children, it was clear that we really have to change how we give these messages. I can only speak as a pediatrician, so I'm going to be talking to parents about parents to young children. I imagine adolescents is another group. We have to figure out how to make them understandable and actionable. And I think the research has to really address those issues because I think many of for those of you who know anything about health literacy, one of the standard ways of testing for health literacy is something called the newest vital sign, which is basically a food label. 80% of the parents I take care of don't pass that test. I mean, I don't give it routinely. I only give it as part of research. But so that says something about just reading a food label to get the information that empowers people to know what they're eating. We need to figure out how to do something about that, not only for children, of course. I think this is for all adults.
So I think all of you have underscored now the importance of education, and specifically nutrition education. Our Undersecretary and Dr. McGinnis also said we need a whole systems approach.
Yes.
So I'm going to ask now, is it education? Is it cost? Is it poverty? How do we approach this systems approach here amongst our vulnerable populations? And I'll let you go first, Lucile.
I think it is a whole systems approach, but I think that we have to make certain we don't make the community, the vulnerable population, the victim.
Right.
And we have to deal with the on both sides of the aisle, because most of the healthy foods we talk about, the things that we need, they're the most costly.
Great.
So you can buy a bag of chips. Right. You can buy all the unhealthy foods for dirt cheap. But what we want people to eat, the fruits and vegetables, they're so high. But more importantly, if you live in an impoverished community, it's cheaper for you to get on a bus and go to the suburbs and buy the same food in terms of the item, but the quality is better, the cost is lower, and we see that, I can tell you, we see that here in this city. And I think that's really a shame, because we want the vulnerable population to benefit from the guidelines and the health education that we provide, but at the same time, there's an unfair system set up. So the suburbs, the better neighborhoods have better food stores, better quality. You'll see the water spraying on the green leafy foods and something, but you go to certain areas, you'll see flies that shouldn't be in the store. And the cost will be higher for the poor quality. So I think that we can't make the vulnerable population the victim. We have to start looking at the producers. The whole gamut has to be involved. So until we do that, I think it's going to be tough to show major changes. Because those corner stores and mom and pop shops, that's not the answer. But even though you put Whole Foods or Harris Teeter in an impoverished area, Whole Foods is whole paycheck. I know.
That's a great line. Anyone else? Ginny?
So I just want to add to that. I mean, we know that 30 million people don't live within kind of adequate distance of healthy and affordable foods. And so we know that we have a huge inequity related to that. We also know that we do need a whole systems approach around access to food, around making sure that our systems are in place and that there's good health literacy. As most of you know, we've just redoubled our efforts around child obesity and made another $500 million commitment. We've made 5 big bets, many of which focus on 0 to 5, because we know about the importance of really establishing those habits early on. All of them focus on ensuring that all kids, no matter who they are, where they live, grow up at a healthy weight, meaning that equity and disparity reduction strategies will be foremost in everything we do. It's something that we will think about in every investment we make, because we will not achieve our goal if we do not. We also have added a domain. We have a policy domain that we work on action, we work on evidence building, but we've added demand. Because to Bernard's point, we can create some supply side changes, we can create these policy changes, but if people don't come, if people don't actually purchase the healthier products, if we don't have mobilization at the local level around policy to ensure that policy is equally implemented and distributed, we're not going to get anywhere. So I think that speaks to some of the conversation around marketing, promotion. How do we, and that requires us to go to the communities and say, if you were going to design a grocery store, what would you put in it? Versus, because you hear back, well, no one's buying the celery. And it's like, wow, well, is celery part of, the diet, the natural kind of everyday diets of this community, or is there a way to really build and design for a community from a grocery perspective, but also I think intervention-wide?
Well, I'm watching this clock that's going to electrocute us. So I want to make sure, although I could talk to you, for the rest of the day probably, I want to make sure that we each take a turn here addressing, you brought up research and the missing research and what work needs yet to be done. So if you could say, each of you, what one piece of research would you suggest needs to happen between now and generating the 2020 guidelines?
So I'll begin. I think I've said it already, but several of us have said this already, but I think research on the first 5 or 6 years of life and how do we translate general dietary patterns into a developmental trajectory of those kids, and how do we make it actionable for parents to be able to understand what those patterns are and how to integrate it into their child's nutrition. Just reflecting on a comment about Hispanic populations being multiple, we have primarily a Mexican population at Bellevue, and in our program to provide actionable materials for parents that people can counsel with, we did focus groups with many of our families and found out how do you take the guidelines and move them culturally into the foods that they have in their house. And by the way, it's eminently doable. It just has to be done. You can't just say, go get celery. You may have to focus on beans and cilantro and things that community is using. I think the other research I think that needs to be done is, again, focusing on your comment about involving the community. We need to do community-based research to really, again, understand how to change the food deserts into food oases, or at least adequate places that parents can get food and also can get the food that's healthy and that they culturally need.
Thank you.
I was just thinking about going into a bodega in the Lower East Side. I have to just say this one thing, and seeing celery, a couple of green vegetables. It was in the back of the store, in a little corner, and that was supposed to be their healthy food section. So that's not going to be the way we change communities.
Ginny, quickly here.
As the doer, as you described me on the panel, I'll say that what we need to learn is how to spread and scale. We have pockets of really fantastic work happening, but we haven't quite figured out how to spread and scale these evidence-based interventions in a way that will really translate culturally to all communities, but especially translate to communities disproportionately impacted by the health outcomes we're talking about.
Thanks. Anna Marie.
Well, you must not have completely read our report, because every single one of their research questions had like 5 recommendations, but it's hard
Actually,
to
I
pick
did.
one.
I was trying to get you to say it.
Well, I really can't pick just one, but I will echo the fact that I think you've hit a very important thing. One of the things that I have to give credit to is the chair of our Dietary Guidelines 2015 committee, who kept telling us, tell me what works. On every single research question we had to say what works. And it's very clear, we kind of know what works. it's how do we scale it up and how do we get complete buy-in and make it a priority for everybody. And then until we do that, we're not going to make these changes. And so if we really want to make a transformational change, we need to know how to scale up and actually how to keep it there. So that's my 2 cents.
I guess mine is buy-in before you can scale up. I'm not from the pediatric side, so I think that it's never too late to make a change. And I think that we have to make certain that we are very inclusive of the adults that may be overweight and obese or have all these chronic diseases. But among the and if you think about the African American community in particular as one of the vulnerable populations, minority populations, often have not been included to the level and extent needed to really understand what's going on in those communities. And I guarantee you that the different pockets, whether you live in the southeast region or the northeast, it really makes a difference. Whether you're Baptist or Episcopalian, it really makes a difference. All these things play into it. And I do not think that we can scale up in certain communities yet until we really buy in and dig in and get away from the idea and the notion that people aren't interested. I think people are really interested, because we demonstrate that in our studies that as we've moved Georgetown. My office is in the community. It's in the Southeast, if you know DC. And we have become a part of the fabric of the community. And so we are now buying in. The community is also definitely our partners, our collaborators. And we're building and creating studies and interventions along these areas that are of interest to the community, and they understand the importance of it. So I would like to have the buy-in and then the scale up.
Lucile, I'm glad you mentioned adults, because one of the things I think hasn't had much discussion is what happens with the elderly? What happens when you move from your 60s to your 70s to your 80s? Is there any consideration of those older folks as being a vulnerable population?
Well, I think the elderly clearly is a vulnerable population, and if you look at the news, this person's celebrating their 100th birthday, their 110th birthday, their 105th birthday. I'm not there. But,
not yet.
But those are vulnerable populations, but they haven't been studied in the 40s, 50s, and 60s, and 70s, so we know less about many vulnerable populations. Mm-hmm. And I come at it from the cancer side, and we know obesity and overweight have been linked to so many cancers, but people are now living so much longer. So clearly that's a void in the science that needs to be addressed sooner than later.
Thanks for bringing that up. As the countdown begins here, I'm just going to suggest what I think we've heard here a little bit in the panel, is that the dietary guidelines might benefit by having a developmental perspective, which would break our population into different age groups, at least broadly speaking, in different categories, looking for some adjustments then within those different groups. But I didn't hear from the panel, so I'm checking in with you. I didn't hear that we needed to change the dietary guidance per se to different populations, maybe by age or developmental trajectories, but not different versions, but rather the interventions could be tailored. In other words, one set of guidelines, but tailor the interventions, not the guidelines themselves to different groups. Did I hear that right?
So we didn't use the terminology developmental. We use the terminology life course, which seems to resonate very well depending on the field. But we basically talked about using a life course approach to be able to identify the different nuances of implementing the dietary guidelines across the life cycle. Because clearly, as you have just pointed out, healthy aging is becoming something that we're more aware of. And so, in fact, I would think that in the next version of the dietary guidelines, that we would have more of an emphasis on what's needed in order to be healthy aging in that, older as we all get there, spectrum of the age. So a life course perspective in the sense of how do you tailor and the nuances of the dietary guidelines on what works, could be, to some degree, when you think about the earlier phase, some of it is not so much changing the types of foods, but recognizing the fact that there are different overall nutrient needs across the life cycle that you should be considering.
Making adjustments for.
Yeah, I would just add to that I do think there are some different nutrient needs, as if you brought up, especially in the first 2 years of life, which are, as we've said, there's a lot of work being done on that now, but also through adolescence that are in the guidelines, but I think they're somewhat different than other different age groups. And I think life course is a reasonable way of thinking about the developmental changes. But I would like to expand the early part of that life course, because my only problem with the word life course is it seems very long. And so the first 6 years gets kind of compressed to about this much, whereas I think, in fact, we have to expand that and look with more of a magnifying glass on those age groups.
So I think that's an important take-home message out of this panel. I think another important take-home message is that more applied research needs to be done so we can learn how to translate and scale up effective interventions. I'm just going to toss in 109876. That means that USDA and HHS need to fund the work that's recommended in research in order for us all to advance. Please, let's give the panel a round of applause. Thank you so much.
Thanks so much for being on time. We actually have some time for questions. So,
we do?
We're not going to let them go quick.
It went to 0.
Did you feel the shock, by
I
the
did.
way?
Boom.
Could you tell we all got up?
We actually have some interns with wireless microphones that are standing by. Please raise your hand, and we'll get a microphone to you. I see a hand right here. I'm going to be charged with pointing at the people that should ask the question, so why don't you please go ahead.
Yeah, thank you. This was truly an excellent panel. My name is Yvonne Bronner, and one of the things that we know is that people live in context, and I think all of you have pointed to what's coming down on them, if you will. And I was just wondering, to what extent are we willing to look at what they are experiencing on a day-by-day basis in order to implement these changes?
Who wants to go?
Well, I'll start. I think that's thank you for that question. I think that's a key question, especially when thinking about people living in poverty. But I think people in a variety of aspects of vulnerability. There's a lot going. There are a lot of other stressors in their lives, and figuring out how to fit in nutrition as something that they can focus on and just block out those other stressors is a critical issue. I personally think that in primary care and medicine, we can do a good job of doing that, but I think that's also where it gets back to their communities. Their churches, their daycare centers. We have to act, the schools. I think we have to go really be in the communities with those people and find out how we can help them deal with the stressors, also ameliorate some of those stressors so they can focus on good nutrition.
So, Yvonne, thank you. Natural question from you. But I think we can only get after that through qualitative research. If we don't hear the voices of these individuals and what they are experiencing, like you brought up with some of the work that you're doing, we will miss it on these large quantitative surveys. Yeah. You don't get that richness of the information. While I'm an epidemiologist, I've done several focus groups predominantly on pregnant women and understanding what their rationale is about making food choices and what guides them in how they view weight gain during pregnancy. And the one thing that I've been absolutely amazed at is the fact, and I think a lot of people will agree with this, that we've lost the translation of how to cook across generation. And so if in fact we're telling people they should be eating more fresh fruits and vegetables and more natural, people are sitting there saying, how do I prepare it? I don't know how to cook it. So it's really through understanding, going back to the community, getting the focus group, that we will then be able to identify what it is that we really need to do. And sometimes it's really starting with the basics.
Great point, thank you.
This audience is doing great, but I want to mention the stage lights make it almost impossible for me to see you. So when you wave, put some motion into it. So we have the gentleman in the center section here with his hand up, and you're over there. You're next, please get a microphone to her. Thank you.
Thank you for your excellent presentation. Keith Martin from the Consortium of Universities for Global Health here in Washington. Two things. One is as a vehicle for sharing. National Geographic is a wonderful program with the Jane Goodall Foundation, the Roots and Shoots program. That may be a vehicle to share that quite widely. And the Reebok program has a box program for getting kids physically active in that aerobic zone, which we know is important for physiological effects. My question, though, is would you support labeling of foodstuffs so that double bacon cheeseburger is actually known how many calories are in it on television? And how do we actually make that $1 apple affordable for those who are in the low-income bracket? Thank you.
Lucile, you want to take a shot?
So do I want to label that, the calories? You know, this is back to the comment that was made earlier about reading labels. I could read this sandwich is worth 1,500 or 2,000 calories, but in what context does it really impact everyone? Until people really understand what the goals are, for the caloric intake for the day, what they have a bigger appreciation of the nutrition aspect of it, I don't know if it really helps. The people who know better and understand it aren't the populations we're trying to get to. It's the individuals that really don't have that health literacy or can see the number, read the number and all, but what does it really mean? I think that's an issue. So I think there's much to be done in that area. In terms of how to get the apple for $1, that's exactly the issue. Who do we go after? I mean, but we got to stop taking it out on the community. And that's what we do so well, and we do it so often. And I don't know how we change the marketing. I don't know how we do that side, but to me, that's a very important side to address.
So I think that's where our report has gotten a lot of criticism, is the fact that we've gone out beyond just food and nutrients, but talked about the environmental policies and how our agricultural policies are not in line with the dietary guidelines. And so while I don't have the answer, I do believe that we need to get things in line, which is exactly what Dr. McGinnis said, is, if we want to be able to support the dietary guidelines, we have to have policies. We have to have subsidies that actually enforce and allow the dietary guidelines to be implemented.
Please.
Thank you. That last comment, sorry.
It's on.
This is on. Oh, great. Hi, Lucy Sullivan, 1,000 Days. That last comment goes to the heart of my question. Thank you for highlighting the fact that children are the poorest segment of our society. And it's interesting because we know now obesity, some of the gains that we're seeing in the reductions in obesity are not reaching the lowest income children in particular. So fundamentally, these issues are issues of poverty, and making food more affordable. It's not just about food deserts. It's not just about making sure that, putting grocery stores in low-income neighborhoods. It is about making those foods affordable. So strongly encourage more action advocacy towards the affordability of fresh fruits and vegetables in particular. Thank you.
Right down here in the center section.
Good morning, Tama Block from Abbott Nutrition. And I just wanted to mention that I think USDA has some excellent websites already available for people who live in food deserts and people who have limited income, and how to prepare food and different foods to purchase in order to follow the dietary guidelines. I think it's really a lot of the education and teaching, and as you've talked about in the communities, offering those programs and having people actually come and learn how to use the database and how to actually prepare the meals at home. And I think it's a really wonderful resource already there. We just have to get them there.
Yeah.
Let me just make a comment. I was a part of the Women's Health Initiative, and I can tell you that the demonstration kitchen was one of the best aspects of that study. Not the outcome, but the demonstration kitchen was one of the best aspects. And people really learn how to have the right flavor, the right taste, but by changing their diet. So I think some of these projects that could incorporate demonstration kitchens, people really buy into that. They really like learning about it. And then we even had competitions to see who made the best tasting food at a lower caloric intake and a higher quality diet. So I think some of those activities could be brought back and really implemented, and you would see that people really buy in. The community does buy into that.
I just want to make a comment about resources on the web, for example, and education being needed. I think when we use the word education, I'm always a little concerned about it because I think of people sitting in seats like this, hearing people talk at them, and I think we really need to be talking about active learning, motivational learning, and behavior change, and empowerment, actually. So I prefer those words almost to the use of education.
I think also, you know, food is, why this is so hard is food is so integral to culture, having nothing to do with health. So sometimes, you know, those of us in this room get really wound up in figuring out how to make sure that, you know, health is a part of the food piece. So how do we use these demonstration kitchens? And it may be a framing issue, that it's not, you know, it's not a health issue, it's an issue of passing traditions across a community, across a family, and how do we do that in a way that people feel like part of that tradition, that responsibility, is making sure that their kids, their families, their neighbors are thriving, and that food, you know, healthier foods is a part of the, you know, kind of that thriving community, the protective factor that we know exists with the family and community meal. So I think I just don't want us to lose sight of kind of the broader picture, because, you know, I do that too. I get really wonky about this and that, but the reality is that we're actually trying to shift in a completely different paradigm.